we'll now take some questions. Tim's got the microphone. So.
Thanks so much. Jason Beattie from the Daily Mirror. Do you think, given the substantial and fundamental changes you're recommending, that the bill is amendable, or do you think they should come back with a new piece of legislation?
Well, that's not for me to say, really. As chairman of the forum, we were tasked with a role to listen to patients, the public and staff, and to come up with some recommendations. It's now for the government to come back, and we look forward to hearing their detailed response, and that will then determine what happens with the legislation. I'm relying on Tim to hand the microphone around, or have we got another one over there with Kate? Thank you.
Thomas Moore, Sky News. Is it possible to have competition and collaboration working side by side?
Yes. Jeff, do you want to answer that first, and then Stephen?
Okay, so my answer in relation to the integration point would be that what really counts is integration on the ground. So for patients in their own homes, can they get a service that combines what their GP would want for them, what the community health services would provide for them, and what social care would provide for them. And so I do believe that it's important that we look at how we can collaborate more on the ground. There are a number of examples, like Torbay, for example, where they're doing that and delivering improved services and more efficient services as a result of that. In order to get that, then I think you do need to have models where there is joint commissioning between local government and between the NHS, and there is integration between the levels of the NHS, primary and secondary care. So that will be my answer in relation to the integration point and the collaboration that's taken to do that. I personally believe that you can have competition as well, so that when you're looking at who's going to provide that combined service, there's no reason why you can't use competition as a way of trying to up the quality of the service responses and the choice of service responsibilities for service recipients.
Stephen?
I think the government got it wrong on competition by proposing that Monitor had a duty to promote it, and I think that set hares running that they didn't need to do. I think that competition has a place in the health service. I do not think competition is a disease. I think there is strong evidence that competition drives quality and certainly drives choice. In fact, I don't see how you can have choice without a diversity of providers. We've heard evidence about the role competition could play, and what we're suggesting actually is, rather than a duty on Monitor to promote competition, we reverse it and actually look at how we can give citizens the chance to challenge the system to get more choice and to challenge poor service delivery. So in my report, I'm suggesting a range of changes, which Steve has talked about, to establish a citizens panel to hold the system to account and report to Parliament, a right to challenge. This is a right that is enshrined in the current localism bill and which needs to be put into the health service so that citizens themselves can. It's a bit like bottom-up regulation rather than top-down regulation by Monitor. I'd like to see this debate moved on, and if I can just refer you to the very last paragraph in my extraordinarily beautifully written introduction, where I say, finally, I have concluded that it is an error to suppose effective and properly regulated competition threatens the fundamental principle of an NHS that is universal and free at the point of delivery. The reverse may well be true, that it helps protect the NHS into the future. We need to move the debate from whether or not competition works to how best to maximise the benefits while minimising the risks. And it is in integration that I think that competition can play a particularly strong role.
Okay. Kate, do you want to hand your microphone over that side?
Nick Timmins from the Financial Times. On the consortia, I'm not clear whether you're saying there should be doctors and nurses on the consortia, or whether they're hospital doctors and nurses on the consortia, or whether they exercise the risk through these clinical centres and these other routes, and actually it should consortia should be GP-led with some independent voices? If so, which independent voices?
Okay. Yes, we heard, as we were going around, enormously from people almost universally that there should be involvement of a wide range of clinicians and others in the commissioning processes. What we did also hear was a very strong voice saying we shouldn't be going for tokenism, and actually there was much more around the skills that were needed to ensure that the clinical commissioning decisions were made correctly, so that the people who sit in the governing element of the consortia should ensure that they have got those skills. Now, in fact, it's likely to include a range of the people who want to be involved. So we've heard from nurses, from doctors who are specialists in hospitals. We've heard from allied health professionals and a whole range of other people as well. And many of them would have the skills to do that. So that's the recommendation we have made, that the right skills should sit around that table. But in addition, whenever you want to commission something, there's a whole range of other people you might well want to involve. So if you're commissioning, for example, Parkinson's services, there's a whole range of specialist nurses, doctors and others who you might want to involve in that. And you'd want to set up a group who would be working either as a network or as a community of practice or whatever, who could advise and input into that. But the decision making we heard and we felt was in a slightly different way, so the consortia would retain that decision making requirement and approach.
So I'm still not clear what the answer to the question is. Do we have hospital doctors and nurses sitting on consortia as a right?
Well,
or is it still GP-led?
there are, obviously, if you look at our paper, there are GPs will lead that process, because the end of the day they're tied into the consortia through their own practices, but there will be a wider range of people involved as well as just GPs, so it will no longer just be GPs.
I think to add to that, Nick, having been around seeing lots and lots of pathfinders around the country, I've yet to find one which isn't involving a nurse actively in leadership role and in working on the pathways. And they will work and want to work with specialists. But if you were to just say a specialist, how are you going to choose that particular specialist? You want, as Kathy quite rightly said, the skills either around the population management, and so if you're in Sandwell, they've got a very good diabetologist who has wonderful knowledge and skills that you would really want to get involved. In other areas, it might be someone from mental health or elsewhere, and it really should reflect what's needed locally. Stay there, and then if you want to pass your microphone across, Tim.
Sam Lister from The Times. You've obviously had a lot of contact with the Prime Minister, the Deputy Prime Minister, the Secretary of State during this process, and they are well aware of what the recommendations are going to be. Is there anything within this report that you think that they won't accept?
That's a very good question. We've spent a lot of time with them, all of us have, and we've been around the country for 8 weeks. And I think what the papers are a distillation of what we've heard, which has evolved over 8 weeks. And even in the last 2 days of the listening exercise, we were picking up new issues. We haven't spoken to them in detail about every issue. We had a very, very good working hour this morning where they could quiz us on anything, and did for the whole hour. And we look forward to their response.
I'm Dave West from HSJ. You talked about the management, loss of managers, and also some of the things in the report appear to require management cost. Do you think the government, there's a very steep target for reducing management cost, do you think that needs to be weakened?
Do you want to answer that, Julie?
Not really, I will.
It's quite clear that a lot of people have already left the health service, and there were some good people amongst that. I think it was also true that the targets to reduce management had to happen. To actually put a figure on that and say what's the right target and what isn't the right target, I don't know. The NHS is a big organisation. It needs efficient management. It needs effective management. And sometimes I get very annoyed when people start talking about pen pushers and all the rest of it, because these pen pushers in my hospital, the ones who write appointments out to patients, who actually write information for patients, they're as just as vital a part of the team. But talking about numbers of it doesn't really matter. It's about the quality of management we need to have in the health service. I have a great concern good people won't want to come into the health service anymore because they're constantly knocked by politicians, and it carries on right through. And actually that's not right. They do a good job. And one of the things that has distressed me, I'm from a hospital, and the fixed points in healthcare are hospitals and GPs. But actually, of all the people that sometimes have been berated in the press as being bureaucrats and pen pushers and all the rest of it, they were doing a job they were asked to do. And there were people who did a job to the very best of their ability. And I think it is not appropriate to then slag them off. I think it would have been far nicer to say thank you for what you've done for the health service. We've found a different way of doing it now, but actually thank you for what you've done.
I mean, I think today actually should be a turning point in that we've heard a lot of distressing rhetoric over the last a year or so about managers and bureaucracy. It's right that we need to have a bureaucratic light system, but we believe that managers have a really key role to play in patient care. The managers we've been talking to have the same values and beliefs about providing high quality care as do the doctors and nurses. And the NHS Constitution recognises that. And I think we should be now talking about all of the health staff, all of the same values, all the same beliefs, and let's actually give them the thanks that they deserve. And let's move forward together in the NHS. Managers, doctors and nurses will all have to work differently in the future. If care moves out of hospitals, a lot of it will be in community care, and managers as well as clinicians will have to work differently in a different setting. So we're all in it together, but we can't afford to lose our best managers. That's a very strong message.
Victoria MacDonald from Channel 4 News. Can you just explain for me what you mean about freeing the NHS from day-to-day political interference, but Secretary of State remaining ultimately accountable? It sounds almost meaningless, actually, if you don't mind me saying so.
Thank you. A lot of people have been very concerned in group meetings and in the press about what appears to be written in the bill, which appears to change the Secretary of State's responsibilities if you read back to 1946. So we believe that it should be clearer that the Secretary of State is responsible for the NHS, but the day-to-day management of the NHS should be delivered by the people on the ground, led by the NHS Commissioning Board. So universally, we've had fed back that the idea of a commissioning board is good, that politicians shouldn't intervene in micro decisions as they did, if you remember, years ago when we talked about, I think it was Bedford Hospital and the patients there. These should be sorted out at a local level and with the NHS board. But of course the Secretary of State should ultimately be responsible for the NHS as a whole. We better go this side. Thanks.
Corinne Dondy from OBV. I'm just taking up on the moving together remark that you said. I think in total you said there were 31,500 people that you spoke to. That was 25,000 and 6,500. But there has been anxiety and concerns about what's going on. So there was sort of strike action called by nurses. 38 Degrees has had 250,000 signatures calling for the end of the health bill. So I'm just wondering, where do these groups of people fit into your listening exercise?
Well, look, we've been hugely encouraged with the feedback about what the NHS is, the values of the NHS, and the fact that the NHS needs to change. In the meetings we've had with nurses, the Royal College of Nursing particularly has been hugely helpful in putting meetings together, but we've met with nurses and doctors and patients at hospitals and in practices around the country, as well as in open meetings. We've had some really robust discussions. We're not here to defend the government, we're not here to defend the bill, we're here as an independent panel. And what you have in front of you are our collective views based on many thousands of people's testimonies and comments and thoughts. We've also been watching the Guardian blog daily and looking at what that's had to say about us and the NHS as well. So I think really this is a very large listening exercise. It's given us a lot of food for thought, and certainly I've changed some of my thoughts over this 8 weeks as well. So all I can say is we're giving you today the papers which are our best attempt in an 8-week period to consult with many thousands of people. I'm going to pass it to Adam.
Adam Brimelow, BBC. You've talked about the need to move services out of hospitals. I wonder how much opportunity you've had to consider the associated issue of hospital reconfiguration and closures, particularly when you're talking about a right to challenge. I wonder if you could give us any guidance on how reconfiguration processes might work under the proposals you've made, and how that could be facilitated where necessary.
Well, that's a very important question, because decisions will need to be made about individual services as well as hospitals. If the government takes on our recommendations, then you'll see strengthened health and wellbeing boards, which will have a stronger view locally about what services for the whole population, health and social care, could look like, linked into the commissioning consortia. You'll also see through the clinical senates a coming together of clinicians of all professional groups, including social care, who will be able to talk through what is needed. And then ultimately through working with the commissioning board, and then ultimately through to the Secretary of State, decisions will then need to be made on reconfiguration. But what we're trying to do, as Stephen quite rightly said earlier on, is try to get more of the decisions made locally where we can. And as you'll know, Adam, when you start to look at reconfiguring staff, patients don't have the information often to understand why decisions are being made about their local services. And in the ones I've been involved in, the clinicians don't always follow the evidence either. And I think what we need is more patient and public involvement, but also professionals need to act professionally. Do you want to?
Yeah, good. Can I say to that, I was struck as a relative outsider to this process coming from the third sector. I was struck by the fact that 70% of the health service budget is spent on people with long-term conditions, and yet the focus of much health debate is about hospitals. And in fact, people who have long-term conditions, 18 million of them, don't actually regard themselves as patients, because of course they aren't. They are people who are living with and managing those conditions. They're citizens. And I think part of what we were suggesting in our paper was the focus needs to move from hospitals to how we provide integrated care in that area. And that inevitably will raise questions about where resources go and whether we get resources right. And one of the things that's emerged out of this in a way that I don't think was in the bill is how integration is important, how we need better working between doctors and hospitals, between charities, social enterprises, private sector providers, who can put together integrated care packages for people with long-term conditions. That's why I think competition can help drive that. But it's also about the system thinking differently, and the system really putting some thought around how you drive that integration. And frankly, for the health service moving forward in the next 20, 30 years, if we don't get the balance better between community support integrated care and hospitals, then we have a serious problem. And that's why the right to challenge, I think, as a sort of, bottom-up regulation will help drive some change. Personal budgets, again, will help drive change. It's a challenge to the system.
Thanks. We take down here.
Hi, Martin Beckford from the Daily Telegraph. Just on the transparency, I understand about making consortia and foundation trusts publish board papers. It also says in your introduction paper, significant providers of NHS-funded services should be required to publish board papers and minutes and hold meetings in public. Would that include independent providers, and how would you force them to do that?
Well, we've had this debate. It's come up a lot of times, particularly when you talk to people in the NHS proper, if you like, about if foundation trusts are going to have to open their board meetings, then why shouldn't private industry? There is one way of doing that, which is through the commissioning and contracting process and creating transparency that way. But yes, it's a bit of a challenge, but I personally believe, and what we've heard very clearly as well, supports the view that if it's taxpayers' money, the population should actually have a say in how it's spent, and they should certainly know how it's spent. And it's part of this whole big theme which will come out of the papers about information and transparency. So if you don't have the information about a service, how can a patient make a choice where to go for their operation? How do they know how successful a particular GP surgery is compared with another in their one-year cancer outcomes? Because frankly, our one-year cancer outcomes in this country are not very good compared with other parts of the Western world. So how can patients choose? How can you choose where to spend your money? But you also need the information on what the money's being spent on.
Do you think, have you had any responses from independent providers as to whether they would be willing to go along with that?
This is for the government now to take forward, and I look forward to their response.
Michael Crick, BBC Newsnight. You've not long ago reminded us you've only had 8 weeks for this exercise. You've twice told us that certain things you only concluded or realised in the last couple of days of, maybe not the last couple of days, but the last couple of days of the listening process.
Yeah.
The Prime Minister and his colleagues only got the final reports 2 or 3 hours ago. I get the impression it's all a bit rushed. Wouldn't you have been better off with a bit more time?
Well, if you talk about productivity, I don't think we've stopped for 8 weeks. So you're certainly out of the 5 of us up here. We've given up most of what we've done in the rest of our lives over the last 8 weeks. Julie has been trying to run an acute hospital and has had a very good team doing that. We've all been the same. Stephen gave up his day job for 8 weeks. We gave a confidential copy of the paper on Friday evening before we'd done all of the typos to the Prime Minister, the Deputy Prime Minister and the Secretary of State on a promise that they wouldn't leak and we wouldn't leak, which actually has been pretty well held actually over the last, a lot of people thinking they know what's in it. And we met for an hour a couple of hours ago. So the answer to your question on whether this is a bit rushed, we only had 8 weeks. We, I think, would all say that there are some areas which need a lot longer to work on. So our proposals are that Julie's area on education and training, we need to sort out the medical part of the deanery so that medical education doesn't fall apart. But actually, why hurry with the rest of it? A home needs to happen for the workforce staff. In Kathy's area, more work needs to be done on networks, and there needs to be more work done on the assurance process of consortia. And the whole area of public health needs a lot longer looking through. So what we've done is we've said, well, this is what our thoughts are here at 8 weeks. These are the things which will help you, we think, with the bill and the NHS to move forward. But actually, if you don't move forward, the NHS actually is already, with some of the PCTs, there's hardly any staff left. If you go to some of the SHAs, very few staff. You actually need to move forward, and dithering wouldn't be helpful at this point either.
But isn't it ludicrous that, I mean, okay, they may have had confidential copies on Friday, but isn't it ludicrous that the senior ministers should react to your work within 4 days? I mean, normally they'd have 4 months.
Well, we're all working very fast. I mean, our anticipation is that we'll have a response generally from them tomorrow, but it'll take a little longer to go through all the detail. I mean, this morning we went through high level some of the detail. It was very challenging, very helpful actually. But we look forward to them telling us what their timescale is for that. Just pass the microphone around.
Okay. Randy from the aforementioned Guardian blog.
I thought you needed a blog.
Yeah, I'm not blogging this bit question. I'm just asking, where does the economic regulation bit go? Because you sort of say, Monitor will keep the powers, but the OFT would then deal with any challenge under competition law. How does that work? Because the OFT would then hand over their documents over to... Sorry, Stephen, it's on page 11 of your summary of recommendations.
Thank you.
I think you're answering this one, Stephen.
The issue of, it's one of the issues that we looked at, the concurrent powers provision, and what we were told and what we were convinced about was that because of this issue of European competition law, we were told and we agreed that by having a health sector regulator and not an economic regulator, that was a better guard against the EU competition law than actually giving the powers to the Office of Fair Trading.
So the dedicated regulator would stay within Monitor, it just wouldn't have a...
Monitor, rather than being seen as an economic regulator, is seen as a sector regulator for health. And the point about that is it ties in with our recommendation that you remove the duty to promote competition. Duty to promote competition, the fact it was called an economic regulator, had too many echoes with sort of, regulators in utility as opposed to health. And that's why we thought it was important to make that change. But we did not think it was right that we remove the concurrent
See,
powers.
just changing those words, economic regulator to sector regulator, does that make a blind bit of difference to what's actually in the bill?
I think it's a signal, actually. And I began by saying I think the government were wrong to give Monitor that power to promote competition. And I think it said, as I said, all sorts of hairs running about competition, that somehow competition was going to be the driving force for Monitor, whereas in fact Monitor ought to be the body that regulates, to stop bad practice and to protect citizens and consumers' rights. So actually it's quite an important signal, I think.
Yeah, we've, as you would imagine, had a lot of advice and talked legally about various issues, and we've discussed with Monitor as well as the department and others, and heard lots and lots of views on this. A lot of what people fear about Monitor, actually, if they were doing their job, is unlikely to happen. And what we've been trying to do is actually get them into a situation where you do need a regulator in the health sector. But if their prime responsibility is actually to encourage collaboration and integration as well as competition, it doesn't become a regulator such as Ofcom or Ofwat or whatever. We think the language that's been used about the regulator over the last few months has been very unfortunate. And if we were starting again, we wouldn't start off as we are now, would we?
I think the other point to make is in our recommendations about the choice mandate that the Secretary of State would give to the NHS Commissioning Board. The choice mandate actually making clear that the primary purpose of competition is to drive integration and to drive choice. That's the framework within which Monitor as the regulator operates and within which consortia boards operate too. So that sort of choice framework really rams home the point that the purpose of commissioning board, the three parts of the duties of Monitor, the commissioning board and consortia are there about driving choice, and competition is to aid
Yeah.
that process.
So I think we just want to be clear. We believe that competition has a role in the English NHS.
Yeah.
We believe choice in its many forms is important. And we had some really interesting discussions with doctors actually who said, well, we don't like competition, we don't like choice. We live in a rural area, why, we just want a good hospital. But if you talk through and role play out the interaction between a GP and a patient, even with something like hay fever, you have choices about whether you go to your GP, which GP you go to, whether you go to the pharmacy, whether you treat yourself or not, what treatments you have. There are different forms. When you start to look at an integrated pathway like diabetes, there are lots of decisions you make along that tree. What's missing in the English NHS is information and the transfer of information between each of those groups that are involved in the integrated care model. I mean, what you need, patients need their records actually. They need access to their records, and they need to be transferred between the GP and the specialist, the GP and the physiotherapist, so that actually continuity comes in the record, and the patient should be involved in writing in that record. But the system at the moment is very, very fragmented. And when you meet with lots of people who are very worried about the bill, they tell you about the worry of fragmentation of the health service in the future. I tell you, it's very fragmented now. Thanks.
Channel 4 News. I've been jotting down phrases you keep using, particularly when you were talking about the role of the Secretary of State, but also monitor. People were concerned about what appeared to be written. A lot of things people feared unlikely to happen. Hairs running, language used unhelpful. To what extent do you think you've been dealing with presentational issues in the NHS reforms? To what extent do you think there have been bad things substantively that you had to change?
Well, I think there has been a presentational problem. I think some of the really good things in the bill have been lost in translation to patients and health care professionals out there on the ground. I think part of it is communication, not from any politician or the Department of Health, but also sometimes you get senior professionals and commentators actually raising concerns which really aren't there sometimes, so there's misinformation sometimes. And then there are things which we do not believe are helpful within the bill, of which Stephen has articulated about monitor very, very clearly. When you look at the education and training paper, it's not yet ready for taking forward. There are issues in clinical leadership of consortia which fall out of the bill, which we believe we will make a very positive impact on if the government responds favourably to our paper, but that is up to them. The indications from the discussion we had earlier on was very positive.
It even sounds like, even on monitor, it sounds as though that you think their substantial fundamental idea was right. They just got a bit overexcited with their language, and that set hairs running. That's what you're saying, isn't it?
I think there's a mixture of the language about monitor. Some of the people who've been commenting about monitor, even from monitor themselves, the language was very unfortunate some months ago. But actually there is detail in the bill which we believe by these recommendations will actually make it an effective sector regulator. It should not and should never have been set up as a utility regulator like the regulator for water. Healthcare is different. In order to meet the needs of the future, you will need competition, and therefore you will need a regulator to make sure that that competition is fair. Yep. And in some areas, you will need competition because the services are not good enough. It's regulation and competition. But if we get this right, I think we can have a truly world-class health service focused on the needs of the individual patient, where you've got health and social care coming together to meet those needs. Because if over 70% of the funding of the NHS is on long-term conditions and mostly in the elderly, we have to be more efficient, more patient-focused, more personalised, and therefore the principles of the bill are very sound.
Oliver Oak from The Independent. You've handed in the report now. Have you had any discussions with either the Prime Minister or anyone in government about what role the Forum might have in future in terms of the implementation of some of the proposals that you put forward?
Not formally, no. We've had an indication that they, today, have said that they felt it was working well, and that they were encouraged when they came out with us on how people were more open and discussed things. I mean, if you think about the number of people we've met in the last 8 weeks, over 6,000, and the number of interactions, the feedback's been very, very positive. And so there was a comment about it is successful, therefore perhaps the forum should continue in some form, but we haven't had any discussions about that. But that was just a feedback because it had gone well.
But not on a full-time basis.
That's all we've had, nothing else. We had 1 hour meeting earlier on with the 3 key players in this, where they questioned all 5 of us in great detail on aspects of the paper. They all showed, all 3, a great understanding of the issues, and it was a very constructive and positive meeting, and we look forward to their response.
Simon Lewis, HSJ. Going back to the having clinicians on consortia, involved in consortia commissioning decisions, you said that you're not going to, well, it sounds like you're not going to mandate having a nurse or a hospital doctor, specialists on the boards, but whose responsibility is it to make sure that they do go to them with commissioning decisions, and how is that going to be enforced?
Yes, I mean, I think what we certainly heard was that we don't want to be able to prescribe, and as Steve has explained, you need individual areas to be able to do that. But what we have been very clear is there needs to be a requirement through the authorisation process, and then through the annual review that the NHS Commissioning Board will do with the consortia to ensure that the right involvement and the right approach is taken, so they have the right skills there, and they also take account of multi-professional clinicians when they're designing services. So it will be an ongoing issue, which could change over time depending on the requirements of the local population.
And we do have a recommendation that there should be a representative of the clinical senate on the health and wellbeing boards.
Okay, so, last question then, go on.
Yeah, one very quick.
Time expired, you see. Microphone.
I'll shout.
Yeah.
You've mentioned records and information so much. I wondered why you hadn't done a separate paper on them. Are you actually happy with the government side and strategy? Do you think they should make any changes in it?
I think extra work needs to be done on information, and we haven't had enough time, as I think it was Michael was saying earlier on, to get into the detail. So what we've given you is what we could do over an 8-week period. It's not complete. There are other areas we would perhaps have got into like that, and it's now over to the government to decide whether, it wants us to do whatever it might want us to do. We've all learned such a lot. It's been a tremendously rewarding experience over the last 8 weeks, meeting people we wouldn't have met perhaps, that we've met and worked with very closely. I mean, just meeting with Jeff's local authority colleagues and teasing out some of the issues, for me personally has been hugely rewarding. And I think it's been an exercise where the government can learn a lot from the process as well as from the detail.
Are you offering them to carry on in some of the areas where not enough work's being done?
If asked.
They'll
have to pay me more. They'll have to pay me more. As in, they pay me bugger all.
It's been hugely rewarding. It's entirely up to the government. And it would be lovely to do something with the Guardian blog again. That's been great. And thanks. And we had a fantastic open meeting at the Guardian, which was, I think, one of the most challenging experiences of my life. But I sort of got out alive in the end. Anyway, thanks very much to Chris Hammond, the King's Fund, for here. Thank you all for coming. I hope this has been helpful, and we're happy to continue the dialogue. Thank you.